Welcome to JACC This Week. I'm Harlan Krumholz, Editor-in-Chief of JACC, and this is the November 18th, 2025 issue, and it's a good one. The focus of this issue is adiposity, and we've got a great portfolio of content. But first, let me start with my editors page. The partnership, editors and authors. Let me read you the beginning. I was wrong about what an editor does. When I began this role, I thought the job was primarily evaluative, to assess submissions, make fair judgments, maintain standards. That work remains essential. But after 2 years and thousands of manuscripts, I've learned something more important. The editor's real work is not gatekeeping, it's partnership. And the most important partnership is with our authors. I wrote this not to diminish the partnership with many other constituencies of the journal, including you, the readers, the listeners. In fact, probably you are the most important, to tell you the truth. But look, without the authors, there's nothing to provide to you. And look, the idea for me is, how can we work synergistically, constructively with the authors to provide the very best content for our readers? I wrote, editing is not simply about deciding what's worthy of publication. It's about collaborating with authors to help their best ideas reach full potential. I further wrote, our goal at JACC is to publish field-defining work, studies that withstand scrutiny, change practice, and inspire new inquiry. But our larger goal is to strengthen the fabric of cardiovascular science itself. I hope you enjoy this piece. It's really about our philosophy, how we're trying to relate with the people who are providing the content, how we're trying to help them, how we're trying to reach out to them, and how we're trying to be kind and generous in our interactions. I end by saying, when we get that right, we do not just publish better papers. We make science itself stronger and move a little closer to what brought us all here in the first place, to make a difference in people's lives. Okay, let's move on to the original research articles, and there's some good ones here. Let's start with adiposity-related anthropometrics and clinical outcomes in heart failure with mildly reduced or preserved ejection fraction, a participant-level pooled analysis of randomized clinical trials. This was an ambitious effort. These authors brought together 5 international randomized trials that enrolled adults with heart failure with mildly reduced or preserved ejection fraction. This is a participant-level pooled analysis. They actually got the data on each individual in these 5 randomized trials. And here's what they tried to do. They wanted to explore the association between different adiposity-related anthropometrics and clinical outcomes. The idea stems from our appreciation that body mass index is probably not the best way to measure adiposity. It's directionally correct, but for any given individual, it could misdirect. We're searching for the very best metric that can help us understand adiposity in its relationship with outcome. In this article, they look at body mass index, waist circumference, waist to height ratio, and they relate those to heart failure and mortality outcomes. The first major finding was that in this trial, elevated levels were common for all of these. 46% had a BMI greater than or equal to 30 kilograms per meter squared, and 95% had elevated waist circumference or waist to height ratio. Among the individuals who had a BMI less than 30 kilograms per meter squared, 89% had excess abdominal adiposity. BMI showed a complex J or U-shaped association with clinical outcomes, whereas higher waist to height ratio was linearly associated with increased risk of heart failure and mortality events. The younger participants had the steepest association between BMI or waist height ratio and cardiovascular death or heart failure hospitalization. I think one of the major things here was to show that there were many people with BMIs less than 30 who had larger waist circumferences or waist to height ratios, and that for them, this demonstrated that a substantial number of the individuals who might not be identified by a screen of BMI had substantial adiposity. And that measure was associated with clinical outcomes. Kudos to John Ostrominski and team for pulling this off. They conclude by saying that waist circumference or waist height ratio assessment identifies a substantial number of individuals with obesity and higher risk despite a BMI less than 30. The editorial by Hall, Spruill, Mace, and Hall say it's time to stop the obesity paradox talk. They state that BMI does not distinguish between lean mass and fat mass and may not always reflect excess visceral adiposity, a major driver for hypertension and diabetes, that are major drivers for heart failure. They state that waist circumference or waist-height ratio are more reflective of visceral abdominal adiposity and provide a more accurate assessment of how excess adiposity adversely affects health outcomes. And they suppose that some of the prior studies that have identified this paradox, whereby people with lower BMI had better outcomes, might be because of misclassification as a result of the problems with the BMI measurement. In what you could consider a companion article, Anthropometric Measures Cardiovascular Outcomes and Treatment Effects of Finerenone in Cardiovascular Kidney Metabolic Disease, Ostrominsky again pulls together a pooled participant-level analysis of 3 global trials. These are different trials than was in the prior study. Here they looked at about 19,000 participants with available data for all of the anthropometrics. In these studies of finerenone, 52% had a BMI greater than or equal to 30, and 98% had any excess adiposity. That sounds eerily similar to what we heard from in the prior study. These trials were enrolling people with type 2 diabetes and CKD, or heart failure. In this pooled analysis, BMI, waist circumference, waist to height ratio, and waist to hip ratio were each significantly associated with a range of cardiovascular outcomes. And interestingly, those with elevated BMI and elevated waist to height ratio experienced a higher rate of cardiovascular death compared with those who had either BMI or waist height ratio alone. The finerenone effect was consistent across all these categories, though the absolute benefits were greater among participants with higher adiposity. Of course, these are the people with higher risk. Their central conclusion is that the assessment of anthropometrics capturing abdominal obesity, in addition to BMI, may enhance obesity identification and risk stratification. Again, if you look at the figures in this study, you see that kind of U or J-shaped curve for BMI, but you don't see it on waist to height ratio. It's really more linear. In the editorial by Gorder, Memes, and Velkusen, they ask whether or not we're now cracking the code of central obesity and wonder if anthropometrics are enough. They write, quote, "The timing of their study coincides perfectly with the growing recognition of the importance of quantifying central obesity, and they remind us we have to look beyond BMI to better estimate individual CV risk. They wonder whether we should be doing more imaging to get direct measurement, though they acknowledge the potential side effects of widespread use of CT for such indications." The next paper is Cardiovascular Effects and Tolerability of GLP-1 Receptor Agonists, a systematic review and meta-analysis of 99,599 patients. You may ask if we need another meta-analysis in this area. Well, look, that's what we asked when it came in, but we took a look, and this was the most comprehensive assessment that we had seen. And we thought it might serve our readers well to see all of the studies together. The authors state that previous meta-analyses had been limited by restricted populations, omission of recent trials, or incomplete safety synthesis. They did a comprehensive view that integrated the latest evidence across 21 RCTs in diverse populations. Their 21 trials included 8 different GLP-1 receptor agonists. The mean follow-up was 2.4 years. When you put all that data together, what they found was a GLP-1 receptor agonist could reduce all-cause death with an incidence rate ratio of 0.88. Also, CV death with an IRR of 0.87 and MACE IRR 0.87, all compared with controls. The GLP receptor agonist reduced severe adverse events by 9%, lowering myocardial infarction by 15%, acute kidney failure by 9%, heart failure by 15%, and infections by 10%. They did increase gastrointestinal 63% up, gallbladder up 26% disorders. They found no differences in stroke, pancreatitis, or neoplasm. And there was good consistency across the subgroups. This is a pretty powerful verdict, one that's been emerging from the different studies, but is great to see all together. Here we have drugs that lead to weight loss, attack obesity, and most importantly, improve outcomes. Now, do we need more evidence? Sure. Do meta-analyses come with caveats? Of course. But this is the most comprehensive look I've seen, and it continues to give me confidence that these drugs have great potential. And we in the cardiology community should be understanding obesity as a disease, recognizing that we need to pair non-pharmacologic intervention with these great tools that we have now to be able to help people get sustained progress, and mostly not to lose weight, but to gain health. I look forward to more evidence emerging, but the momentum is in favor of these drugs, the evidence momentum. If you want to catch up with all the evidence that has been generated, the figures in this study are terrific, and it can be a one-stop shop to really bring yourself up to speed. Nichols and Nelson write the editorial. They talk about the GLP-1 receptor agonist revolution and ask, is it time for everyone to get on board the incretin train? They say that this analysis reaffirms an increasing body of literature that has demonstrated clinical benefits of agents that target incretin hormone receptors. They also acknowledge that the uptake of these agents remains suboptimal in their opinion. I agree. They write that the development of these drugs has the potential to be the most transformative change in cardiovascular prevention since the emergence of statins. I want to give kudos to the group that put together this systematic review. Gali, Scaretta, and the whole team. This is a terrific group. They've done this kind of work before. This is at the highest level of meta-analysis. Our next study, natriuretic peptides, body mass index, and clinical outcomes in heart failure with mildly reduced or preserved ejection fraction. Ostrowinski again, I guess you could say this is his issue, and the team. In this study, they're evaluating the association between N-terminal pro-B-type natriuretic peptide with clinical outcomes in individuals with heart failure and mildly reduced and preserved ejection fraction, stratified according to BMI. They're leveraging the challenges related to interpretation of natriuretic peptide levels in persons with obesity. Natriuretic peptide levels in individuals with obesity are typically lower compared with those who have a lower BMI. Higher natriuretic peptide levels are associated with greater lipolytic activity. So in this study, what they did was pulled together 4 global randomized clinical outcome trials. Does this sound familiar? They're leveraging the idea that they can bring together these trials, and they've been able to obtain participant-level data. So they can do participant-level pooled analyses and look at these associations. That's why we're so enthusiastic about the 3 studies that they submitted. They were able to put together a dynamite database and ask questions that were very relevant, all related to adiposity. In this study, they had almost 15,000 participants, mean age of 72, 50% female, with a mean BMI of 30. The median NT-proBNP was 836. Higher baseline BMI was significantly and nonlinearly associated with lower NT-proBNP levels. Look, that's what you would expect. That's what we know. That's actually why they did the study. They had a follow-up period of almost 3 years. Each doubling of the baseline NT-proBNP was associated with a 40% higher covariate-adjusted rate of cardiovascular death or heart failure hospitalization. But here was the key. The association was, as they term it, blunted with higher baseline BMI, and the interaction was highly significant. What they conclude is that current NT-proBNP thresholds substantially underestimated the absolute risk of adverse heart failure outcomes among people with a higher BMI. So what they're essentially suggesting is that maybe for people who have obesity, there should be lower NT-proBNP cutoffs. I think we ought to be looking at these as continuous variables, but yeah, maybe people are on a different line depending on what their adiposity is. Based on the other studies, I don't know the BMI is actually the best, and maybe this study should be done through the lens of looking also at waist-to-height ratio. The implications are important, though, because for our patients with obesity, we may have been underestimating the risk as we were leveraging the NT-proBNP. They conclude by saying that these findings underscore the importance of tailoring interpretation of natriuretic peptide levels to the broad dynamic range of BMI, rather than to the presence or absence of obesity alone. Reddy and Borlaug wrote the editorial, Obesity-Specific NT-proBNP Thresholds for HFpEF, Are They Better? They take it in a little different direction. They say the present study raises the question of whether we should continue to obsess with NT-proBNP for diagnosis and enrichment or whether we should consider alternative, potentially superior biomarkers, which do not experience this high dependence on body composition that biases toward the exclusion of individuals living with obesity. And they introduced the idea that C-terminal proendothelin 1, mid-regional proadrenomedullin, and maybe others would be more preferable. The next study is sex differences in effectiveness of semaglutide in patients with peripheral artery disease, the STRIDE trial, led by Subodh Verma, senior author Mark Banaka. The objective of this study was to describe baseline characteristics, functional status, and therapeutic efficacy of once-weekly semaglutide, 1 milligram, between men and women with PAD and type 2 diabetes. This was a post hoc analysis from the STRIDE trial. As a reminder, the STRIDE trial was a randomized placebo-controlled study in individuals with symptomatic PAD and type 2 diabetes. In that trial, once-weekly semaglutide, 1 milligram, significantly improved maximum walking distance, pain-free walking distance, health-related quality of life, hemodynamic parameter ABI, and reduced disease progression over 52 weeks. It was a pretty big win. Here they wanted to look at the sex differences. They had 792 participants. 195 were female, 597 male. At week 52, there was consistent improvement in maximum walking distance. Improvement in pain-free walking distance was consistent across sexes, as was PAD-specific quality of life. Their central conclusion was that semaglutide was effective regardless of sex. Sala, Reimer, and colleagues wrote the editorial, Semaglutide in Peripheral Artery Disease, a Step Towards Sex-Specific Care. They leveraged the finding that women in STRIDE exhibited a different baseline risk profile than men, with fewer cardiovascular comorbidities and a higher prevalence of never smoking. They opine that these differences may reflect sex-specific biological variations in vascular disease expression, including smaller vessel caliber, greater microvascular dysfunction, and heightened inflammatory response. They do say that despite these differences, the effectiveness of semaglutide was similar. They say, quote, by confirming efficacy in women who are often diagnosed later, are treated less aggressively, and disproportionately experience disability, these findings address a critical evidence gap and move the field toward more equitable PAD care. In this issue, we also have a JACC state-of-the-art review, the basics of metabolic dysfunction-associated pathophysiology, diagnosis, and treatment. Look, I think this is an emerging trend. We in cardiology are now looking very much at obesity. We're thinking about kidney disease, we're thinking about brain disease, and we're thinking about liver disease, especially when we're talking about cardiometabolics. This is by Khan, Fudim, and colleagues. It's a distinguished group, and they do a great job. They lay out that metabolic dysfunction-associated steatotic liver disease is recognized as a multi-system disease now and is closely linked to cardiovascular disease, which is why we in our community need to pay attention. They make the point that metabolic dysfunction-associated steatotic liver disease and cardiovascular disease share overlapping pathophysiologic mechanisms, including insulin resistance, chronic inflammation, oxidative stress, and endothelial dysfunction. This is a great review to bring yourself up to speed on this issue. And recognize, as we talk about cardiometabolic disease, we can't be demarcated by just focusing on the heart. Cardiologists need to have a literacy about this. This review covers epidemiology, diagnostic approaches, and therapeutic options. We have another state-of-the-art review, Obesity and Acute Pulmonary Embolism, Clinical Implications and Knowledge Gaps, by Zuin, Klock, and colleagues, another great group who've put together a wonderful primer on this topic. They start by saying that obesity presents unique clinical challenges in the management of acute pulmonary embolism, and that we need to take those into account if we want to optimize patient care. It complicates diagnostic accuracy due to technical limitations and influences both pharmacologic and interventional treatment decisions. There's some great figures. It's a great synthesis. I highly recommend it. We have a special communication from Packer, Borlaug, and colleagues, chronic kidney disease in patients with heart failure with preserved ejection fraction, the underlying role of visceral adiposity. You know, we've spent a lot of time focusing attention on this idea of the adipokine hypothesis and the role of adiposity in HFpEF. In this piece, they argue that visceral adiposity is not only the prime driver of HFpEF, but it's also the principal determinant of its association with chronic kidney disease. This is part of a series of special communications that we're publishing together from Packer and colleagues. In the second one, is type 2 diabetes a modifiable risk factor for the evolution and progression of heart failure with preserved ejection fraction? Here they argue that diabetes-associated HFpEF is mediated primarily through its association with excess adiposity. I wrote a viewpoint with Silvio Inzucchi that both affirmed what they're saying, but also said that it may be a little bit more complex in our piece that we said beyond adiposity, embracing complexity in diabetes-associated HFpEF. We suggest that hyperglycemia is still in the picture here. We write that as appealing as parsimony can be, few cardiometabolic diseases are governed by a single pathway. We suggest that the pathogenesis of HFpEF in diabetes is a complex, multifactorial, and heterogeneous condition. We show respect to the efforts by Packer, and their work is erudite, but we call for the pursuit of rigorous studies to distinguish hypotheses from proof. We say it may be most constructive not to view hyperglycemia, insulin resistance, and adiposity as competing hypotheses, but as co-conspirators in a complex and evolving story. And then the third in the Packer trilogy with Borlaug and colleagues, central adiposity or hypertension, which drives heart failure with preserved ejection fraction. So they took on kidney disease, diabetes-associated HFpEF, hypertension-associated HFpEF, and their central argument is that at the root of it is adiposity. And in this piece, they argue that central adiposity appears to be more important than hypertension as a determinant of the evolution and progression of HFpEF. Petrie, Doherty, and McMurray write a viewpoint, What is Heart Failure with Preserved Ejection Fraction?, where they explore some of these issues in greater depth. They basically opine that HFpEF is not just caused or driven by obesity or hypertension. Look, all of this is about a healthy dialogue. In each case, people are showing respect, people are putting out ideas. I think it's very healthy. It's a great place for JACC to be. I would say all participants of this dialogue were calling for more research to test hypotheses. And I applaud the development of these hypotheses for us to debate, think about, and to drive the field forward. In this issue is also an ACC scientific statement, the 2025 ACC scientific statement on management of obesity in adults with heart failure. Michelle Kittleson chaired this committee, and it was a group of experts who have produced a document that truly will help you understand what you need to be doing today to care for these patients. This statement reviews the diagnosis, evaluation, risk assessment of obesity in heart failure, describes heart failure-specific management strategies in lifestyle and medications and surgery, and addresses evidence gaps in future directions. We also, as usual, have an Amara Yad image. I hope you enjoy it. This week's, it's the 4-chamber view, the superior segment. With that, we're at the end of the issue. I know it's a little bit longer. I hope you've enjoyed it. Give me feedback. Is this a length you like? Would you like it shorter, longer? I appreciate hearing from you. And that's JACC This Week, November 18th. Thank you for listening, and stay curious.